Welcome to the WSPID Podcast. We're your hosts for this episode, Dr. Linny Phuong
and Dr. Alicia Chang. In this episode, we are diving deep into RSV or respiratory syncytial virus. If you are a parent or a pediatrician, we know this virus has been causing concern the past few months, and there's quite a lot of misinformation floating around out there.
For the purpose of this episode, we're focusing on preventative therapies to RSV and the latest research on maternal immunization. So I think, Alicia, first of all, RSV is an exciting virus to talk about, given the number of developments and changes that have happened in the last 12 to 18 months. What have you seen in your practice?
Well, RSV really is always in the spotlight in my country, and in general in Latin America has been causing a lot of burden of disease, a lot of collapsed hospitals with very sick babies. So last year was a really bad year for RSV, and I think we are all ready to finally have good news about this disease and how can we prevent it.
Yeah, so similarly in Australia, we've seen, lots of RSV within the seasons. We saw that things changed during the pandemic and, things perhaps in terms of trends became a little bit skew-iff in terms of those usual epidemic seasons. But what's been exciting is the introduction of nirsevimab, so the long-acting monoclonal antibody, because previously we were just using palivizumab, and then the introduction of the two vaccines, so the vaccine in the elderly population, as well as the RSV vaccine that's coming for pregnant women.
To dig deeper into this topic, I spoke to the wonderful Dr. Flor Muñoz, Associate Professor at Baylor College of Medicine and Texas Children's Hospital.
Let's hear how your talk with Dr. Flor Muñoz went.
Thank you, Flor, for being with us today.
My pleasure.
She's an associate professor of pediatrics and infectious diseases at Baylor College of Medicine and the director of Transplant infectious diseases at Texas Children's Hospital in Houston, Texas. She has published extensively on topics related to influenza, RSV, vaccines, and of course, maternal immunizations, which I believe is one of her passions. Flor, thank you for joining us.
Thank you for the invitation, Alicia. And this is a very timely topic, so I'm happy to be able to talk about RSV with you today.
So just to let our audience know, we are not using real names on patients, and we have just adapted some case that we have managed in the past, but all the information has been altered to be able to use it in this podcast. So let's start with a case, because we clinicians love cases. Lucia is a 2-month-old little Guatemalan baby girl who was born full term through a C-section. And the indication for this C-section actually was a previous C-section. She was born actually without complications and was discharged home with her mother. Lucia's mother decided to exclusively breastfeed her, and she has been gaining weight, and she has been also developing fine for a 2-month-old baby. Now, we are going to imagine, Flor, that we are managing this case, and specifically, you get this call from Lucia's mom, and she tells you that she has been noticing that Lucia is coughing just a little bit, and she's not running a fever though. And she also noticed that she is a little bit less interested in feeding. So you tell her that you want to see her in your clinic, but unfortunately they are very far away from Guatemala City, which happens a lot here in our country. And she tells you that she will try her best to bring her in the next day. So the next day, Lucia is at your clinic, and immediately when you see her, you see that Lucia is working hard to breathe, and the color of her skin is a little mottled, and she's cyanotic around her mouth. So, Flor, what tests do we have available, and what kind of management do you think that she will require at this point?
Well, first of all, let me just say, depending on where you are in the world, you need to be thinking of different things, and that is based on your local epidemiology. But also, given the age of the baby, even though this was a term baby, um, in the first couple of months of life, babies are very susceptible to a lot of diseases, a lot of maternally derived infections that you can think of as late onset sepsis can happen at this time and present very indistinctively with respiratory symptoms, GI symptoms, just overall decreased activity. So that has to be on the top of our minds, and meaning that it is concerning that this baby is already having trouble breathing and has turned a little purple around the mouth. Baby is in stress, right? And so anything from bacterial pathogens to whatever the baby who could have been exposed out in the community is a concern. And so certainly with respiratory symptoms, you do need to worry about what is circulating in your community. And at this age, babies usually depend on their antibodies from their mothers. And so if moms happen to not have had exposure or vaccination to certain viruses like the flu and now RSV, then babies could be susceptible to those. But there is a number of different pathogens, right? So in terms of diagnostic tests, like you mentioned, after you stabilize the baby and after you make sure the baby is receiving fluids, oxygen, airway support, and that you collect some samples to be able to determine whether this could be a bacterial infection. So blood cultures, urine cultures usually are necessary. The next thing to do would be to have respiratory samples. And usually what we would recommend is to do a nasopharyngeal swab or throat swab or a combination of both. And if you have the capability, actually utilize PCR testing, so molecular testing, to do a variety of viral and bacterial tests. So typically, for example, in my institution, in the urgent care settings in the emergency room, we would have what we call an admission rapid test that will give you a result, molecular based, very quickly, that will test for RSV, flu, and also COVID-19, because that could be also a pathogen in their differential diagnosis. And you can get a result pretty quickly within a couple of hours. If we needed additional diagnostics, you can have a multiplex PCR or something that gives you more details and get tests for rhinoviruses, adenoviruses, human metapneumovirus, which needs to be in the differential as well because it presents very similarly. You also have mycoplasma, you can have pertussis, a number of other pathogens that could be considered in this case. So I think, nevertheless, the most important thing here at this point is that even before you have a result from your testing, that you do take the next steps that are necessary to stabilize the baby. And as I mentioned, even potentially start antibiotics on a baby like this until you know what is happening, because they could deteriorate very quickly.
So this baby was actually rushed into the emergency room, and she was put into oxygen on a nasal cannula first. And then she was rapidly set up to start a high flow nasal cannula. And blood cultures were taken, CBC, inflammatory markers. And we were able to do an RSV antigen, and it comes back positive for RSV. So now we know that this baby has RSV. And in fact, as a matter of fact, she was started on antibiotics, and she was left on antibiotics for the time being during her first hours in the emergency room, and then she was admitted to the hospital. Once the baby is stable and she's in her room with her high flow nasal cannula, she's stabilized and everything, then the mother is finally able to ask you some questions, and she actually doesn't know much about RSV. So it is very puzzling to her, I suppose, how a virus can get a baby so sick so rapidly, because she was just talking to you on the phone the day before. She didn't think it was such a big deal to say that way. And also, she wants to know if there's anything that she could have done to prevent that disease.
Sounds great. Well, it's not surprising. Let me just say, since I mentioned molecular testing and you said that you had a positive antigen test, actually for RSV, that is a good option. Unlike maybe flu or other rapid tests that are antigen based, actually the test for RSV is quite sensitive and quite specific. And so if that's what is available to you, it's totally okay to try to identify RSV via antigen test as opposed to molecular testing. And I also think that if a baby has no fever and you have a good CBC and potentially a chest x-ray where you don't have any evidence of a low-borne pneumonia or anything concerning a bacterial infection, the likelihood of a bacterial infection at the same time as RSV is relatively low. So it's prudent to start on antibiotics and then take them off as soon as you are able to confirm that there's no bacterial infection. And then, in terms of answering the mother's question, it is interesting. We have this surprise many times, especially from parents that have their first child or they have not had experience with young children, because as a matter of fact, as you know, RSV is the most common cause of lower respiratory tract disease, so bronchiolitis and pneumonia in babies, especially in the first 2 months of life. And what happens is that these babies are going to be exposed to anybody in the community, and that most children, older children and adults that have RSV, because we all can get RSV, don't have a very severe illness. It might look just like a cold or common respiratory illness. But when babies are exposed to this virus and they get infected in the first few months of life, especially the first few weeks of life to be specific, that is the classic presentation, a 6-week-old baby with rapidly progressing respiratory distress that ends up in the hospital like this baby needing respiratory support. It is because they have been infected in the community at a time when there is circulation. So mom would need to be aware. I think that this is a very common virus, that you get it from other people, that there's nothing, that she did wrong about this baby, that sometimes this is actually very contagious and just by contact, so touching or just being in an environment where other people come and go that might have had this virus and being in contact with surfaces and all that, you can get exposed. Certainly, one thing that we do recommend with newborn babies, especially, is that ill persons, so anybody who has some respiratory symptoms, especially, are trying to avoid being in contact with these newborns and very young babies, because again, they can be infected very easily and they don't have any chance of really having protection unless they have maternal antibodies for this.
I think that when you are confronted with these parents very worried about their kid and they get so sick, and they do feel guilty a lot of times because they think that they should have brought the baby in earlier. Actually, this disease progresses as I mean, it's one of the fastest virus that progresses in little babies that I've seen. So not I mean, very few viruses do this, and I think for me as a pediatrician, RSV is one of the worst. Now that we have this background, Flor, in this case, which I believe most of our listeners have had many times, because as you mentioned, it's a very common cause for bronchiolitis in small babies. And since you are an expert in RSV immunizations, we're going to take advantage of that and ask you a few questions about immunizations, because I think we all in the medical community are very excited about RSV immunizations in moms and in babies. So let's start with the moms. And since I know it's been a very hard work to have this vaccine available for moms, I want you to give us a little bit of insight of the all the ways, all the roads you guys have had to walk through to be able to have this vaccine available actually for moms. And then we'll talk about what's available for babies, if you are all right with that.
Sure. And then, maybe to put things in context, I think what is important to realize here is that the most severe RSV disease happens very early in life. So we're talking about a case just like the one you presented, where it's really in the first 4 to 6 weeks to even 8 weeks of life that you have the greatest severity. And that means babies end up in the hospital and babies could even die from RSV disease. And it is a biphasic illness. So many times it just presents initially like a little upper respiratory illness, and then babies get better, and then all of a sudden they get worse. So this is why sometimes it's difficult for parents and even providers to recognize how severe these babies can become. But the key is that, unfortunately, there's no vaccine that we could give to babies early enough to help them get protection in time for when they go home and get exposed in the community. This is similar to pertussis, for example, whooping cough, that again, before we can vaccinate babies at 2 months of age with whooping cough vaccine, that is common and available, they can get exposed before that, and they have the most severe disease, hospitalization, and death if they get whooping cough in the first 8 weeks of life before they're vaccinated. Because we don't have a vaccine for RSV that we could give that early, because babies also don't respond to vaccines that early. It would need to be later. You have that window of time where you really have very highly susceptible babies until they grow enough and their airways, their lungs grow enough that they can support themselves and survive an RSV illness. The most direct approach has been considered for decades at this point to provide passive immunity to these babies. So giving them immunity that would mimic what happens in nature. So what happens in nature is that, if a mother herself has had RSV in the past, or if she's had it recently, especially during pregnancy, if a mom gets a cold, that happens to be RSV, then they actually have antibodies that naturally go across the placenta. And that's what protects the babies, especially in those first 2 months of life. And then the antibiotics wane and drop over time. And then, the baby's old enough and grows well enough that they can survive and do well even with an RSV infection. So the idea of protecting the babies through passive immunity is not new at all. We've been, the medical community has been working on this since the 70s and 80s, actually starting with giving just high dose, high titer RSV immunoglobulin to babies early on. That changed into giving, some directly administered passive antibodies, pre-made antibodies to the babies. And this is great, but the ability to give this antibody is costly. So it can be a very expensive intervention, and it works very well because it's mimicking nature. So because it's costly and it could not be given to everybody, considering again, we do have higher risk groups, so it was mainly used to protect the very young, the premature babies and those with heart and lung disease, so that they would not get sicker from RSV, because we know they are at even greater risk than healthy term babies. Nevertheless, it is actually healthy term babies who have represent the majority of the cases, just by numbers. There's a lot more healthy term babies out there. And study after study has demonstrated that if you look at the epidemiology of RSV in any place in the world, the majority of the cases are healthy term babies. So we couldn't give until recently any passive immunity directly to those healthy term babies. So the concept of giving a maternal vaccine has also been there for decades, because basically what you would be doing with a maternal vaccine is giving a boost to a mother during pregnancy who probably has been infected. Keep in mind that by age 2, all of us have had RSV, whether we know it or not. So basically, every woman who's of childbearing age is going to have antibodies to RSV. So if she gets a vaccine in pregnancy, she's going to boost up her antibody titers, and that's going to be transferred naturally to the baby through the placenta. And so the work for this began, again, I would say, I don't know, from the 1980s at least, many, many years ago. And the key with this has been identifying what the target in the virus is for antibody development. So what is the part of the virus that elicits the higher titer antibodies that actually are going to neutralize the virus? And there were some vaccines that were tested early on, not just in pregnant people, but, in other high-risk populations, because other high-risk groups, patients immunosuppressed, chronic lung, heart disease, could also get this bad RSV disease. And unfortunately, the vaccines were not immunogenic enough because they were not targeting the right antigen, the right place in the virus. So with technology that was able to help identify that this one piece of the virus called the fusion protein in the surface of the virus is actually the target, and that it actually has to be in a very specific conformation, which is the conformation the virus it has before the virus can enter the respiratory cells. That this is what opened up the opportunities to develop vaccines that would then be able to be effective. So the long way to this has been trial and error, developing candidate vaccines that have had different targets, but now I'm telling you, maybe in the last decade, with the proper target and the proper vaccines, finally, there were clinical trials that demonstrated that the vaccines were immunogenic, so they elicited good antibody responses and were safe, not just in adult populations, but specifically in pregnant women, so that phase 2 and phase 3 clinical trials were conducted, and of at least 3 different prototype vaccines that were tested, one of them actually was successful, and this is the vaccine that we have since last year, approved in the United States and several other countries in Europe and Latin America, at least one country in Latin America, where this vaccine can now be given to pregnant people to protect their babies, not necessarily for the mother herself, but really with the goal of boosting those antibodies and then passing those antibodies so that the babies have sufficient protection early in life.
Flor, I think it's fascinating the idea of vaccinating moms, pregnant women. Since I'm from Latin America, I'm going to talk about the things that happen in my region. As you said, there's only one country that actually has approved the vaccine to be given to pregnant women, and I wonder, what are the main barriers that are the ones preventing us from going ahead as a region? Maybe it might be the case in another region, because our listeners are from all around the world, but in Latin America, I think we have a hard time vaccinating pregnant women.
Actually, I think that vaccination of pregnant women globally is not necessarily a difficult proposition. And the reason I say that is because in most parts of the world, including Latin America, Africa, and many other countries in Asia, tetanus vaccination in pregnancy to prevent neonatal tetanus is quite standard and very well accepted. As a matter of fact, in many countries in Latin America, the tetanus pertussis vaccine also has been introduced. And so in addition to protecting, the babies against tetanus and the moms against tetanus, pertussis protection has also been available, and it has been well accepted and implemented. We can talk also about maternal vaccination in the context of flu and COVID-19. And certainly during the COVID pandemic, with its ups and downs, because, there were a lot of challenges related to the fact that the variants were different and that the spread of the variants, was quite fast, and it was difficult to catch up with having vaccines that would match the variants. Nevertheless, I think that the fact that pregnant women were included in the recommendations for overall population protection with vaccine was very good, and the uptake was varied in different places. So what is different is that the RSV vaccine is actually the very first vaccine that has a specific indication for pregnancy, meaning that the other vaccines are available for everybody else, and pregnant women can have them too, and they're included, and again, very well accepted in general. But RSV is not a vaccine that you would give to just everybody else. Right now, there is a vaccine, RSV vaccine, two of them actually available for older people, so people 65 years of age and older who are also at greater risk, but not for anybody, who is not pregnant or more than 65 years of age. And so the idea or the understanding of why a pregnant person should get this vaccine needs to be tied to the fact of understanding what RSV does in babies and how this maternal immunity can help that baby as well. I think that the barriers really are related to decision making at the country level in terms of what intervention is implementable, cost, certainly, and then the surveillance for impact and for safety of these vaccines. Because at this point, as I mentioned, there are other vaccines that we give in pregnancy, and so we are now adding to that. And a lot of providers, so healthcare providers and also the mothers themselves, are being faced with the potential of receiving several vaccines in pregnancy and trying to understand why each one of them is necessary and what happens if they get one or not the other, or if they get all of them in terms of safety and overall impact on their health and the health of their baby. So there still needs to be a lot of learning and a lot of, I would say, logistics planning to be able to get RSV vaccine out to more mothers in the world.
Absolutely, Flora. I find that at least in Guatemala, what we learn with COVID is that we do need to involve all of the stakeholders in the vaccine process. So not only, doctors, of course, nurses, yes. In general, healthcare workers, persons in the community that can help us deliver the message and the understanding of how the vaccine works, and make it a super simple and make it feel safe for the community. Sometimes, in Guatemala, still doctors, they are trusted, I suppose. But still, in the communities, in the rural areas, people need another one from within the community to actually deliver this message, to make it more believable and understandable, I suppose. I think we're going to have a lot of those experiences around the world. What do you think?
Yeah, keep in mind that at least for the RSV vaccine in pregnant people, these the clinical trials were done around the world. So there are sites in all regions of the world that participated. We know that there are geographic and population differences, and so that is also important to understand. But I do think it's reassuring that the healthcare providers and the population at large can see that there's representation of participants in the trials from the region. That's one thing. The other is, just the fact of really the acceptance, like you say. I find that if you look at studies in general about acceptance, the Latin American population, some of the populations in many African countries and Asian countries are very trusting. And it's not even an issue of acceptance, right? It's more an issue of resources and access. So that is probably one of the main barriers, right? At this point, I mentioned, one country in Latin America is able to give the RSV vaccine, and they have a expert group and have policymakers, experts that make a decision about how to best use it in the country, one of the issues has been having local data to really understand the burden of disease, right? So if you don't have data in your country that says RSV is a problem, it's going to be a much harder sell for decision makers to say, okay, let's use this vaccine now when you probably have other diseases that are still needing to be addressed and for which you have to, put your resources into that. So that is also one of the issues, right? It's not necessarily just the acceptance, it's just the priorities and having a good understanding of the burden of disease in your area, in your region, in your country. And many times it is helpful, right? Because you might not be able to generate that data in your country, but you can have regional data. So neighboring countries who are able to generate that information are going to be very helpful to then introduce these interventions to other countries in the region.
Flor, I think this is key. The burden of disease that you mentioned, to generate that data, and then try to connect with neighbors, which is one of the things that we're trying to do through the society, trying to, build the bridges so that we can communicate and we are all available for everybody. I think that more and more we need to understand that health policy has an impact worldwide. It's not only in my city, in my town, in my community, and certainly prevention is the way to go. And we have data to prove that prevention pays off, right? Unfortunately, we are about to run out of time, but I still want you to make a few comments, Flor, about monoclonals, because I know a lot of listeners we're going to have a lot of questions. Probably we're not going to be able to solve them all in this podcast, but at least we're gonna try to go for the basics. Maybe what is a monoclonal antibody, and what are the indications in the case of RSV?
Yes, thank you. And yes, I don't want to leave without talking about monoclonals because the concept that I presented earlier is basically what also supports the use of monoclonal antibodies. So what is a monoclonal antibody is a laboratory-made antibody that is targeting specifically that part of the virus that needs to be neutralized so that the virus doesn't make the baby sick. And the technology has been such that, again, we don't need to give just immunoglobulin or transfusions of immunoglobulin to people, but that these can be made in the laboratory so that you can give a specific dose, and that by giving this to the baby as early as possible in life, you are again you're mimicking what happens with the maternal transfer of antibodies, but instead of expecting the protection to come from the mother antibodies, then you give it directly to the baby. And the big news is that we've been doing this, at least in the United States, for 25 years with monoclonal antibody that was directed to the RSV virus, that was very specific, very efficacious, but it has had a short half-life of about 28 days. So you need to give it every month during the RSV season. And again, that was very costly, limiting who it could be given to. So again, the big news is that the technology that we have now has allowed for modifications in that antibody molecule so that it has a longer half-life, meaning that instead of giving it every month during the RSV season, babies can now receive a single dose that could last up to 150 days, so 5 months or so, which should cover the majority of their RSV season in most places, although keep in mind there are some places where you have RSV circulation year-round. And this is an antibody that again has been studied globally. The studies have been done in many parts of the world. has been shown to be safe with very little, if any, adverse reactions. It's given as a single dose, and many countries started using it already last year or so before the winter season in the Northern Hemisphere, and have started to show very, very nice data because guess what? It is going to work. Just like passively acquired maternal antibodies from the mom who gets the vaccine or given directly the antibody to the baby, we know it's going to work because there's demonstration from decades of work before that what babies need to resist those very first few weeks of life, any RSV infection, is antibody. So this is a very good story because, now all of a sudden, after decades of work, we have both options, giving moms a vaccine or giving the babies directly the monoclonal antibody. And then again, I think that there's no question that both are safe and efficacious interventions. In the United States, at least, the ACIP recommends both. It doesn't favor one or the other. But I think the main issue, again, both in the United States and in all countries of the world, is going to be implementation logistics, right? So resources, the maternal vaccine acceptance maybe, and also the cost is lower versus, the cost a little bit higher for the monoclonal antibodies. Where is it given? When is it given? Because if you really want to, I'll just say this, if you really want to have a similar effect and protect the babies in the highest period of vulnerability, which is the first few weeks of life, you really need to be already at birth having that immunity. So that is one advantage of the maternal immunity passively acquired from the vaccination, is that babies are already born from day one with that protection. And to be able to match that, you will need to give the monoclonal antibody at birth before the baby leaves the birthing hospital or, where the baby is born, so that they're protected during that period of time. And then there's logistics. You need to know your epidemiology so that for both interventions, you need to make sure that the optimization of the intervention will be based on when the virus is circulating. So you have to time the administration based on that. You also have to be able to follow for safety and be able to follow for impact, in addition to all the logistics about who gives it, who pays for it, who's going to talk to the mom, because now that's another piece. We're also not just pediatricians involved. We're also asking our obstetric colleagues. So everybody participating in antenatal care is also asked to help us with this cause to mainly prevent RSV and its very severe consequences in the babies.
I think that this clarifies a lot the concept about monoclonals and what babies are candidates to receive monoclonals. Do you think that in terms of feasibility, budget, and things like that, a lot of countries may opt for one or the other because basically it is expensive to arrange for both things to be paid for?
Exactly. And so this is part of what needs to happen at the country level. I think we're fortunate in the United States because both are approved and both are available. But even in individual institutions, there's decision making that needs to occur, right? And so who can get the monoclonal antibody? Every baby. It doesn't matter whether they're born prematurely, whether they're born term, whether they have underlying conditions. It doesn't matter, what their immune status is, because this is not expecting the babies to make their own antibodies. They're getting the antibody. So this is a ready-made protection that they get on the spot. But it is more expensive and it has logistical issues, right? So you need to make sure that it's given at the right time and so on. Who is eligible for maternal vaccine? Well, right now, it's a particular restriction in terms of when in pregnancy. So you have to be between, in the US, 32 to 36 weeks of gestation, while the clinical trial allows for 24 to 36 weeks of gestation administration. So it depends on, the comfort level of the countries. So there could be, women who may not be able to get the vaccine if it's too late or if they have a baby that's born prematurely. So it's always good to have a backup there so the babies can get it. And then again, it also, nothing of this is going to have an impact if you don't have good coverage, right? So another concern is that, even for the most severe diseases, we don't have 100% coverage for anything. And so having both options is always great. because I don't think we can expect that all mothers will be vaccinated or that all babies are going to receive the monoclonal. But we do want to say, and we would want to protect all babies. And so we want to make sure that this is accessible to everybody. And the more options that you have, the better. There could be shortages, there could be, problems with supply, there could be problems with funding, many things can happen. So I think having more than one option is always good. But of course, countries are going to have to make a decision based on resources as well.
Thank you, Flor. We have gotten actually to the end of this episode, which I'm very sad about because I want to keep talking to you much more. But unfortunately, we have a limited time. However, I want to thank you so much for accepting this invitation. And I want to thank you for your clarity and your knowledge and your time. I know you're a very busy person and you have graciously, accepted to give us almost a whole hour for us. So I hope this knowledge can reproduce many times and that we get to do more about RSV because I think it's something new and people is going to want to know more. So if they want to know more, could you recommend any specific place where they can consult, a web page where they can follow you or your research or your publications about the RSV vaccine?
Thank you so much. Thank you so much for the invitation. I think that, RSV is a big topic right now. So I would recommend the CDC webpage. I would recommend ESPID, European Society of Pediatric Infectious Diseases, WSPID, the American Academy of Pediatrics, ACOG. All of those have very excellent resources that are available right now.
Thank you. Thank you so much, Flor.
Bye.
It's been wonderful to talk to Flor about all of these exciting developments.
Yeah, I'm looking forward to having the listeners also sort of share her wisdom. So another great episode. Well done. For more information on RSV, visit the global e-learning portal on the WSPID website, your hub for pediatric infectious diseases insights.
And that's the end of today's episode. We wanted to say a big thank you to Dr. Flor Muñoz for her expertise in RSV and showcasing the preventative therapies that are providing hope to pediatricians across the globe.
Whether you're on your way to or from work, out for some daily exercise, or doing the school pickup, thank you for listening to the Syndromic Insights podcast. Make sure you're subscribed on your favourite podcast platform so you don't miss an episode. Please share the podcast with your colleagues, leave us a review, and be sure to tune in next time.